Hi, my name is Dr. Emmanuelle Huchet. I'm come from the Clinique L'Actuelle at Montreal. Bienvenue à tous. Today I will talk about the real-life experience of HepC management with interferon-free DAA treatment in Montreal at the Clinique L'Actuelle. We know that the efficacy and safety of interferon-free treatment regimens for HepC have been demonstrated in several clinical trials, but few studies have examined its effectiveness in the real-life clinical setting. Our objective was to evaluate the expected impact of interferon-free DAA on treatment outcome in the real-life setting. It's a prospective cohort study, L'Actuelle cohort. The inclusion criteria was we include all genotype HepC infected patients who received treatment since January 2014 to July 2015. And for sure, we include all the patients who received DAA-based treatment without interferon. The exclusion criteria is patients who've been enrolled in ACT were excluded for sure, and the patient need to follow a model of care. That means they have a follow-up each 2 weeks with a multidisciplinary team. It's with a nurse and physicians. The comparison among treatment groups were assessed by chi-square, and predictor of SVR were determined by logistic regressions analysis. We know that the adherence can be a concern of this type of treatment, so our primary outcome was to evaluate if our patient can achieve the treatment to the end, the EOT, and if they can sustain virologic response, the SVR at 12 weeks post-treatment by intent to treat analysis. We got 38 patients who received treatment with Arvoni and 7% with Alcura. 31% received SimSoft, and don't forget with that we start, that we start a study in 2014, that's why we have this kind of regimen with SimSoft, and we have 25% who receive sofosbuvir and ribavirin. Okay, for the result and treatment initiation at the baseline, we have 249 patients who've been included in the study. 4 are still on treatment. So we will analyze data on 245 patients for the EOT and 200 for the SVR. The others doesn't have sufficient follow-up time available for the SVR. And you can see in our sample, 10 patients over 245 did not complete the treatment. That means 5%. And the reason for discontinuation, we have 4% die. We have 2 got serious adverse events. 2 got a loss to follow-up, 1 abuse of alcohol, and 1 travel around the world. And we have 18, I don't know. And we have 18 patients who are lost to follow-up. That means 9%, and that's the data that we need to remember. For the result of SVR12, we got 208 patients who complete the 12 weeks post-treatment follow-up. We got 37 patients who failed the treatment, no SVR. We got 9 who got treatment failure, 4 died, and 5 were not responder. We have 11 patients who relapsed, and 17 patients who've been lost to follow-up. That gives us a result for 90% for OT and 82% for the intent to treat treatment, ETT. Okay. For the SVR by regimens, we obtain a range between 82 to 86 without significant difference between the regimen. And anyway, the purpose of this study was not to compare the treatment. But if you compare with the clinical trials that we know, normally it's around 92% to 99%, we can see that we have a SVR rate very lower than what's seen in the RCT. And I will show you why we have this kind of result after. Overall, we got 72% of patients are men. The mean age of treatment initiation was 52 years, with no difference in each group. And I'll give you some very important data. 15% was using active drug in our study, and when they received treatment, they have 13% who got the treatment substitutions with methadone or Suboxone as well, 21% abuse of alcohol and when they received the treatment, and 29% got neuropsychiatric disease, and 8% were homeless. Again, no difference was observed between the 4 groups. Data for the genotypes was 61% got a genotype 1A, 14% to 30%, 1B was for 14%, 13% got a genotype 3. And you know that Alcura, Simsoft, and Arvani was given for genotype 1 and 1A, 1B. And for the 2 and 3, it was sofosbuvir with ribavirin. 64% of patients were naive. And you can see, particularly in the group of Alcura, 86%. If you compare with the group of Arvani, was 56%. Co-infected represent 24% of our patients. And again, there were no co-infected among the group of Alcura, but you can see that 30% in the group of Simsoft and Arvani was co-infected. 40% were cirrhotic, and again, Simsoft patients are more damaged liver, with 57% of them presenting signs of cirrhosis, comparing, for example, to the group of Alcura, only 29%. The SVR for cirrhotic patients have obviously a recovery rate inferior to those who have a healthy liver, 75% for F4 and 90% for F0, F1. And the co-infected patients, the co-infected patients still respond less to the treatment, but the p-value is not really significant. In the absence of cirrhosis, patients respond well to the treatment, while in the presence of cirrhosis, reaching SVR remains a challenge. And for the naive patient, all treatment had a similar effect, but in the group of experienced patients, there was not enough patients in each category to compare the SVR. And to see who ended up the treatment, we make a regression analysis and find that the older, the cirrhotic, and the co-infected one are those who have problems to complete the course of treatment. And when we're controlling for potential confounding factor, these 3 factors, age, be cirrhotic, and co-infected, remains independently associated with treatment interruptions. And when, in fact, we include in the regression model all the potential confounding factors, that's demographic, traditional barrier to care, medical attribute, and pharmacologic factor, but the traditional barriers and the pharmacologic factor doesn't impact the discontinuation, but the age, to be co-infected with HIV, and to be cirrhotic, were the predictor for EOT. And for the SVR, we see again the same factor being involved, as mean the treated after 50 years reduce slightly the chance of cure, being co-infected also, and cirrhosis significantly under his recovery. When controlling for the confounding factors, the only factors driving the SVR is being cirrhotic. And again, we test for all these factors, demographic, traditional, etc. But demographic, traditional, barrier, and pharmacology factors doesn't impact the SVR, but cirrhosis is still a break predictor for SVR. In our conclusion, despite the fact that our patient had significant ongoing barriers to care, we have 95% complete the entire course of treatment. None of the barriers to care were significantly associated with treatment discontinuations, but rather the age of treatment, presence of cirrhosis, and co-infected with HIV were factors that impact negatively the possibility to follow the treatment to the end. Is it maybe a matter of frailty, excess or vulnerability? I think so, with the patient who've been co-infected. And that's why in the real-life setting, they offer an acceptable state of SVR, but in our study, we got 50 to 20% less than we see in the clinical trials, and I think because her patient was more sick than the clinical study. And in the new DA era, the only significant determinant of being cured seems to be the magnitude of liver damage, and the presence of cirrhosis SVR continue to be a real challenge. And even with a multidisciplinary team that we have at the clinic like I said, they have a close follow-up each 2 weeks. It seems that at the end of the treatment, we lose them. They have 9% of persons we lost to follow-up. And we still have to find a way to bring them back to the clinic after the end of the treatment. And the thing to say is because it's kind of people who have mental illness, they abuse drugs, and sometimes to come back to the clinic will be a little bit more difficult. And I think the key home message is to treat sooner to get cured, avoid to be cirrhotic, and career is not finished after the end of the treatment. Thank you very much.
So we might have time for one question.
Only one. No.
Thank you very much. Nice presentation. I just had a question around your HIV co-infected population.
Yes.
Are they generally gay and bisexual men, or are they people who inject drugs?
Drugs,
I know,
drug user.
Okay, so because I know you adjusted for those other factors, but
Yeah.
so it is HIV-infected people who inject drugs.
Yes.
So it's,
And
okay.
our co-infected patients are very more sick. They are more cirrhotic. When we evaluate that, the data show that they are more cirrhotic, they are more older too.
Okay, great. Thank you.
Yeah. Merci beaucoup.
Thank you very much.